I feel like this is maybe the biggest future for optometry that's really here upon us. America is aging, and optometry is by absolute necessity going to be called to care more for our elderly population. There are just not enough ophthalmologists to care for all of the aging population needs. So that means glaucoma, that means cataracts, that means macular degeneration. It will be in your chair more than ever as these patients need advanced eye care. And so by 2030, 1 in 5 Americans will be 65 or older. Geographic atrophy is very strongly age related. When you look at studies, 1 in 29 people over the age of 75 years old have geographic atrophy. 1 in 4 people over the age of 90 have geographic atrophy. So as our patients are living longer and we as optometrists are seeing older and older Americans, we are going to see this at really high levels. So it becomes essential that we're good at detecting it and then treating it now that that's an option.
Yeah, I mean, your numbers are right on. My number, I think over the age of 70, AMD affects 1 in 3, right? And so that's pretty significant. And to your point, we're looking at an aging population. One of the statistics I throw around, think about this, every day, 10,000 people a day turn 65. And so as we've got this aging population living longer, this is being recorded in the morning, and I'm at a meeting in Indiana. I was watching the Today Show, and they do this Smuckers over 100, and literally there were 10 people that they just talked about. Some were 105. There was 1 or 2 that was 110, right? And so it's like unbelievable. So yeah, patients are living longer, and you look particularly at GA. We see AMD 65, 70, 75, right? But GA more commonly in that over 80, 85. In fact, I think 20% of GA occurs in people in that 90-year range. So those are the ones, we're going to see it in the early groups as well. And again, we're recognizing and following patients with AMD. But yeah, it's certainly more of the elderly population. And to your point, it takes a village to raise an elderly patient, when you look at all the other potential, diseases, as you indicated, glaucoma, macular degeneration, cataracts, patients with diabetes. And again, optometry, we're on the front lines of these diseases. And I'll tell you, I applaud, the companies like Iveric and Apellis, and even the wet AMD companies like Regeneron and Genentech, right? Because they are paying attention to optometry. They're doing education centered around AMD and diabetes. And again, you and I may never decide which drug a patient gets. We're probably not going to be the one to put a needle in the eye, but we are the ones that are going to diagnose it and make sure those patients get sent to a retinal specialist at the appropriate time. And so, yeah, it does start with education. It starts with recognizing these diseases. And so, and again, to your point, you look at geographic atrophy, a disease that we haven't been looking for. And now there's a lot of education that needs to be done. How do we detect it? How do we recognize it? And shifting our focus away from conversion from dry to wet, man, I need to start looking for geographic atrophy, because if we can recognize it earlier and get it into the retinal specialist, again, our goal to prevent vision loss. We don't want to see these eyes that are 2,200 that have lost central vision. We want to get them earlier and really potentially save vision.
So let's get into detecting these early forms of geographic atrophy. So we're going to review some biomarkers and how to detect the earliest stages of the disease, because the treatment that's available, you have to intervene early in order to get the long-term benefits. We know genetics plays a role in macular degeneration, especially that CFH and ARMS2 alleles. Do you do genetic testing for your patients or recommend genetic testing?
I do not. And again, the American Academy of Ophthalmology has come out against doing genetic testing. Remember, Arctic DX was a Canadian company that I think were pioneers in genetic testing. And kind of the idea was, if you could kind of recognize people who had these, high risk genetic markers, those would be the ones that perhaps we would follow more closely. We would recommend nutritional supplements for. And the problem is, the data was kind of flawed on does that make a difference? Does it make a difference on which genetic supplement you take? And again, just recognizing that AMD is complicated. It's not only about genetics, it's about environmental factors. It's about, oxidative stress. And it's really this compilation of all these variables that predispose a patient to developing AMD. And so the point was, we don't have a treatment, and we're not going to do anything any different to these patients anyway, other than, recommend, not smoking, green leafy vegetables. So a diet that's rich in green leafy vegetables, high fish intake. And so whether you're, have a genetic marker or not, we're going to make those recommendations to our elderly patients anyway. And remember, for people who don't have any AMD, even early AMD, the age-related eye disease study showed it didn't make any difference of taking a nutritional supplement. So it's difficult, right? Do you recommend it or not? Because here's the other side of the coin that I struggle with. So we all have patients who've 23andMe, they've
I
taken.
was going to mention that. I know I have so many patients coming that say, I have a genetic risk.
Exactly. I have the genetic risk. I want to know, do I have macular degeneration? What do I do? And of course you do an eye exam. They don't have any AMD. They don't have any drusen. And what do? We don't really have any data to guide us. So do you recommend a nutritional supplement for somebody who may have the genetic profile but doesn't have AMD? And so, how do you make that decision? So I think we educate them, right? Coming in at least once a year to get your eyes tested. You talk about nutritional supplements, and again, I think to some degree you put it back on them that the age-related eye disease study showed that people who didn't have AMD, there wasn't any benefit, but they didn't study people who had this genetic risk. And so it won't hurt you to take it. There's maybe an economic disincentive because they're not cheap, and so I just think providing information, and hopefully as time goes on, we'll get more information on how to guide these patients. I let people know. I had another instance where a patient came in. My father, he was a 50-year-old, mid 50-year-old guy who, listen, my father lost central vision from macular degeneration. He had injections. I'm worried. What do I do? And so, there's a couple, I didn't recommend Arctic DX, but I said there is a direct to consumer genetic test available. I'm just blanking out on the name right now. So, if you want to do the genetic testing, you can do it, and you can kind of find out, do you have the genetic risk? Otherwise, we're going to see you once a year. We recommend the green leafy vegetables, a diet, exercise, those type of things. So, but again, this is an evolving area, and genetics ain't going away. So I think there's going to be more and more, people coming in, and probably more companies developing genetic tests. And so I think we're going to be faced with these decisions more and more as time goes on.